Not all audible.
66 years old.
Rajesh.
Presented with the NYHA class 3 dyspnea since 1 year, and orthopnea since 1 year. She was diagnosed to have double vessel coronary artery disease and mitral valve prolapse with severe MR, and underwent CABG with mitral valve replacement with 27 mm St. Jude mechanical valve in June 2018. She is non-diabetic, non-hypertensive. On examination, weight is 81.4 kg. Pulse is 72 regular. BP is 120 by 70, saturating 99%. Cardiovascular system examination showing the apex beat at 6th intercostal space, 2 cm lateral to the midclavicular line. There is no heave or thrill. S1 is there is a prosthetic click is heard, and with the S2 normal split. Pansystolic murmur grade 3 by 6 at apex is heard. X-ray is showing CTR of 70% with LV type of apex. Mild pulmonary venous hypertension with mild mitral prosthetic shadow is seen. This is the ECG showing the sinus rhythm, ventricular rate of around 75 per minute. Axis QRS axis of plus 75, PR interval of 180. Left atrial enlargement showing the broad and notched P waves in the lead 2 and terminal negative P wave forces in V1. This is the transthoracic echo showing dilated LV on the apical 4-chamber view. There was a mild TR with peak gradient of 24, normal functioning mitral prosthetic valve with the mean gradient of 6 mmHg. This is the apical 4-chamber view showing the color and the continuous wave Doppler, showing a significant mitral paravalvular leak located medially. This is a plaques view showing the anteriorly located leak. It measures about 8 mm on the right side of the screen. This is the transesophageal echo at 0 degree and 90 degree views, which is confirming the large mitral paravalvular leak located anteromedially. This is the 3D of mitral valve, shows that the anteromedial placed leak, measuring 7.6 mm in this view, and the maximum dimension is about 10 mm showed in this 3D image. On some blood investigation was showing the hemoglobin of 9.9 with PCV of 32.6. Retic count is increased 3.2 with LDH on higher side 247. Total bilirubin is 0.3 with peripheral smears showing the signs of the hemolysis, like many cystocytes were seen, microcytic and anisoporiculocytosis was there. So the final diagnosis was status for CABG plus mitral valve replacement June 2018. Well functioning mitral prosthesis, large 10 mm anteromedial severe mitral paravalvular leak, dilated LALV, adequate biventricular systolic function, sinus rhythm, NYHA class 3, mild hemolytic anemia. So the plan is mitral paravalvular leak device closure. Thank you.
Dr. Rajesh, I think you heard the story of the patient.
Yes, we have looked at the presentation and we have heard that.
So my colleague Dr. Srija is going to briefly show. The plan is, this is a lady who is just freshly operated within the last 1 year and having significant paravalvular leak, and has got some evidence of hemolytic anemia, and the size of the leak was almost close to 10 millimeters, and so it is it's planned for a closure. Now since the leak is anteromedial, it's pretty close to the aorta, it's close to the interatrial septum, it is in the region of right fibrous trigone. It has been our policy in these patients to try a transapical route. I heard that Dr. Gerard is going to talk on apical puncture paravalvular leak device closure. We are going to demonstrate the way we do in our center. There can be an option of doing a transeptal puncture and using a deflectable sheath like Agilis sheath or the Fustar sheaths, which are deflectable. However, the distance between the septal puncture to the place where we are entering the mitral paravalvular leak will be very close, and so it will be tough to manipulate the sheath at that level. So our preference for an anteromedial or a leak that is very close to the interatrial septum has been an apical puncture. I would like to hear the views of Dr. Gerard or the other people in the in your team who do paravalvar leaks.
Jerry?
Now? Yeah, hi. Hi, I think that's exactly what I would do. It's in such a tight angle to get around to that with a transapical makes this way faster and the fluoro time's way shorter, and secondly, you'll need a really big device.
True.
So if you were to come through the interatrial septum with a great big diameter sheath to deploy a big device, it'll be hard because of that angle to orientate the device if you're using a non-round device. And I think this is a much better way of doing it.
Yeah, I think the word Dr. Jerry used, the very tight angle between the septal puncture site to the paravalvar leak, is the precise explanation about how tough it is for a leak that is very close to the septum. Now Dr. Srija is going to tell us about how she plans the echocardiography. Dr. Srija, please.
Good evening. So these are the images recorded in the cath lab. Here we can see the 4-chamber view with a dilated left ventricle.
So this is an apical view that she started off and then subsequently moved to transesophageal. Yeah.
So already we are seeing the medial paravalvar leak. So this is some measurements which we took from the surface of the site of apical puncture up to the mitral valve. It is around 11 centimeter. And from the apical skin to comfortably enter into the LV cavity, it is around 4 centimeter. So approximately at a distance of 4 centimeter, we will be comfortably inside the left ventricular cavity. So this is the mitral valve, a bileaflet valve, which is having a normal leaflet mobility with a normal functioning normally without any gradient. So this is the medial paravalvar leak, which is seen very close to the interatrial septum. In this view, it's measuring around 7 millimeter. So this is showing the same leak with the color comparison. It's measuring around 7 millimeter again, and this is a 3D localized zoomed view, which shows the leak there in the anteromedial part of the anteromedial to the mitral annulus, and the aorta is seen above. This is the same image. And here on a 3D measurement, it measures maximum of around 11 millimeter. So here it's again constantly measuring around 11 millimeter.
So thank you, Dr. Srija. That was an excellent demonstration. Since this patient had a coronary angiogram in the past, I would like to show the coronary angiogram very quickly. Can you go out to the computer and show the coronary angiogram, please? From the computer, can you show the coronary angiogram?
Dr. Sivakumar, do you measure in any other way except for echo?
Is it? No, only echocardiogram. Only echocardiogram by various views. We take the X-plane views, we take the 3D. The entire measurement is done on echocardiogram. Now, can I ask the question, like what other method you are thinking about, like probably using a CT scan or something? Okay. Now,
so I exactly was thinking the same question when Raj asked you. So we actually plan our case with a CT scan predominantly. We also, in this particular patient, you mentioned about double valve, but there's also ways we have done the CT scan with a pigtail in the left ventricle, and we actually do the CT scan with a contrast injector to the left ventricle. That means you see the beautiful hole of the paravalvar leak on the CT scan coming through the leaf if you pick it up and gauge it at the systolic phase. But even without it, we actually marry the CT scan with the echocardiogram. So we actually locate it in the echocardiogram, go back to the CT, and do all our measurements and the planning of depth, puncture site, everything from the CT scan, and we can also superimpose that CT using something like a heart navigator on the day of the case, and we also have the echo navigator that can run parallelly, but it just helps us to plan. So it's one of the ways we do, but you have some beautiful echo images, which sometimes we struggle to get, and sometimes we get dropouts, and we struggle to measure these holes directly, where exactly what size device to use, but your images are excellent.
Yeah, actually, I think a couple of years ago when you had the same meeting in New Zealand, Dr. Carlos Ruiz from New York came there, and he probably he's the expert on a CT guided mitral paravalvular leak closure, where he uses the CT information to even decide about the site of his apical puncture, the trajectory of his apical sheath, everything he decides. In India, we adopt some little simplistic tools to cut down the costs. Now, my colleague Dr. Bhushan is showing the angiogram, and he's showing that the proximal LAD is having a milder disease, and that was the reason why the lima got occluded. Can you go further, Dr. Bhushan? Yeah, keep moving further. Move it faster.
This is of the proximal LAD, and there is a good antegrade flow into the LAD. The caudal view showing the venous graft to the OM as there is a good competitive flow into the distal OM. It means the venous graft is patent.
Be ready. Show that lima injection, Dr. Bhushan.
This is the LO 35-degree view of RCA showing almost 40 to 50% stenosis of the mid RCA segment. The lateral view of the venous graft taken, which shows a patent SVG to OM graft.
It's not playing.
A selective lima shoot was made, which showed a completely occluded lima. So, based on this coronary angiogram, there doesn't seem to be any objective evidence of myocardial ischemia.
What's happening?
Thank you.
So basically there was not much of coronary myocardial ischemia because the LAD flows are reasonably preserved, and so now we did not do a coronary angiogram today because this angiogram was done just within 1 month ago. So we are going to now start demonstrating how we do the apical paravalvular leak puncture. So what we do is we have, as Dr. Srija has pointed out earlier, we have palpated the apex. Get ready to give apnea. So apnea, and disconnect the ventilator. Disconnect the ventilator. So what we do is we give apnea for the patient. We disconnect from the ventilator. Allow the left lung to collapse. Can you see my finger? Go zoom in on it. Zoom in on it. So the marker has already been made based on, you see, this is my needle, and we are palpating the apex, and I am going inside, and the moment I get the apex,
Are you worried about the LAD, distal LAD?
basically the last parts of the LAD are tough to be identified by the coronary angiogram is not going to be effectively be showing, give the long sheath, not going to be showing all the last terminal diagonal branches, and so it has not been our practice except during the initial diagnostic angiogram to have a parallel LAD injection. We go anterolateral on the surface of the left ventricle. Now I am using a flexor sheath. See that now we are introducing the flexor sheath.
What French is it?
This is a 7 French blade.
Through a normal J wire, is that correct?
Yeah, it's a normal J wire which has gone into the aorta. So now I am making a small skin nick on that area.
How did you choose the site of puncture on the skin? We in this patient we are using a 7 French because our target device is about 14 or 16 Amplatzer vascular plug. So we are now on the apex, and we are progressing inside. The moment we reach the left ventricle, now I just take out only the dilator. How long is this sheath?
Sheath is a 30 centimeter. Dr. Srija told me that at around 11 centimeter is the distance between flush. 11 centimeter is the distance between the LV apex and the mitral annulus, and so I have chosen a 30 centimeter sheath. Half of the sheath is actually remaining outside now. I still have not crossed the leak. So now, after confirming that I am pretty secure on the left ventricle, now I am taking out my wire. You see that it's coming out of the ascending aorta. Now give me a right coronary artery catheter.
How did you choose the site of puncture on the skin? Is it the fourth intercostal space or fifth intercostal space?
It is the place of the maximal cardiac impulse, point of maximal cardiac impulse that is felt, which is the lowermost and outermost definite cardiac pulsation. So this is the paravalvar leak. So now timer on. Okay. So now I'm going to be using echo navigation. You see that on the left side of the screen, already I have a marker. Can you go to LAO? LAO. Here. So again thank you, enough. Show more of the heart. Okay, it's again going into the ascending aorta. The sheath has to slightly come.
What wire are you using?
It's a straight thermo. It's a straight thermo.
Is there a catheter in this sheath, or?
There is a catheter. There is a Judkins right coronary catheter with which we are trying to direct. Hold it here. Little bit out.
So do you kind of find the site from what you based on the echo and you are probing around there, or would you?
Can you see that? Can you see on this marker that I am using echo navigation? Are you identifying a white marker there?
Yes. Perfect. Sorry. Yeah, we were not looking at it.
Okay. On the left side of the screen is my echo navigation, and the right side of the screen, left side is the regular fluoroscopy, and right side is the echo navigation.
Perfect.
Okay. Now I am probably losing the. Can you go to RAO? RAO. Yeah.
Possible the echo navigator screen a little larger?
Yeah, echo navigation, I will try to make it larger. Is it okay?
Yes. Yeah, that's better. Thank you very much. So you are also using Philips
Exactly.
extremity?
Yeah. Philips Echo Navigator, we are using the CX50 as the echo platform. This is an Allura Clarity, and so this is going through the valve. Srija is parallelly looking at the echo from the head end. Show me AP view. Yeah. So I'm turned in another direction. Yeah. Show in LAO. Show in LAO. Yeah. Go to LAO. Yeah. Srija. Can you see, Dr. Raj, Dr. Jerry, that is, it is actually in the ascending aorta. Okay.
So we've seen that you've crossed and then checked.
No. Actually, it went into the ascending aorta. I thought that we had crossed, but then it went. Now again, it is going into the ascending aorta.
So The echo doctor, I didn't quite get the name. Is there any role for 3D in this procedure?
Sure.
3D?
Yeah, now we have crossed.
Now we are entering.
Yeah,
Can you see
there
that?
is a 3D.
See, now it is entering into the left atrium. So what we do is we advance the catheter, and now we confirm on echocardiography that we are across. Make the echo screen bigger. Okay, so hold it here.
Very nice.
Yeah, the
Because-
wire is across the leak.
Okay, go to RAO. Hold it together. Contrast. Contrast with it. So the next step that we do is, see, she has, Dr. Srija has shown that we are through the paravalvular leak. Now I am just making a puff of contrast. So at this particular point, I am advancing my sheath across into the left atrium. And now, so what I'm going to do is initially try a 14 vascular plug and see how it looks. And then suppose if it is not satisfactory, then I might try a 16 vascular plug. Dr. Jerry, what will be your choice of the size of the device? I got 10 to 11 on the transesophageal, so on the echo pictures. So I was thinking about either a 14 or a 16. What would be your choice?
So because it's a St. Jude valve, you want to make sure you don't have a big flange hanging over into the mechanism.
Exactly. Yeah, so we don't want to trap one of the leaflets. That is one. And by the way, is Dr. Clare also there?
So a VP3 probably is the sort of thing, because it's not quite round and that kind of oval configuration, probably good. A muscular VSD device, if it was really big, might be not a bad idea either.
Yeah, the reason why we did not choose an AVP3 was the largest AVP3 is 14 into 5. The 14 on the long axis will be good, but the 5 on the short axis will not be adequate. If you are using an AVP 14 by 5, then we probably have to stick in another device as well. We are trying to do it with a single device, if possible with an AVP2. Yeah, as you said, muscular VSD device is also another option. The advantage of an AVP2 is that the profile of the sheath can be smaller. I wanted to know, is Dr. Claire O'Donnell also on the chair?
Yes.
Yes.
Hi,
I'm here.
hi Claire, how are you?
I'm very good. You are obviously very good too.
Okay, fine. Actually, Priya conveyed her regards to you. I actually, for Raj, way back in 2000 when Dr. Claire was in Boston, I was also there, and we came to know about each other. And I sent one of my fellow to Claire, and she spent, I think, around 2 years with Dr. Claire, and she came back far more energized and taking away all the energy of Claire O'Donnell back to India. So
when do you give heparin?
in this particular patient, I put the timer on, and 15 minutes, if I am able to complete, then I don't give heparin. Right now, I am running at 10th minute.
And how much heparin do you give?
I give 5,000 heparin, but right now, I have not given so far, as I told you, water. I'm going to wait till 15 minutes, and if I'm able to complete, actually on a regular working day, we will be able to complete it. Now this is live, and so we are spending a little longer.
So which size do you finally choose?
This is 16 or 14?
16.
14. Okay, sorry, it's 14 now. So I'm going with a 14 now. You see that this is a 14 Amplatzer vascular plug 2. So I have released the distal part of the device. So now, can you get it sent like a cranial or caudal and make the disc completely come perpendicular? Okay. So I'm releasing another 50% of my device.
It's nice to see both the imaging modalities up here at this end, because at this stage when I'm putting these things in, I'm really looking at the transesophageal echo more than anything else, about how it lies and whether it's deploying the whole problem.
Srija, you are happy
Yeah,
with the pictures?
Yeah, yeah.
An excellent demonstration of how the three parts of the device is being deployed also.
It's slipping out.
Hmm.
However,
16.
maybe because the leak is little larger, I will try to see if I can center it onto the middle.
Dr. Sivakumar, this is Sanjeev here. Do you ever leave like a coronary wire or something across through your sheet so that in case things slip out, you can go back in, or the crossing is easy? So
Yeah, that is actually a very good technique. The only difficulty with that technique will be we may have to use a larger sheath, and since I am going apical with the smallest possible sheath, I try to avoid it, but that is an extremely useful strategy, especially if you are doing transeptally. In transeptally, you can afford to have a little larger transeptal sheath, and so in that case, then sometimes we leave a wire. There are times at which we have put in 2 or 3 devices adjacent to each other like a necklace. Now, the position looks satisfactory for me. What? No, actually it is slipping out.
I think it will need
Even if it slips out, Srija, if suppose the leak is
16
getting
would have
settled,
been
then I am okay.
Dr. Sivakumar, how
Yes.
are you adjusting the device where it is in the center? What are you doing? Are you pulling and pushing?
Yeah, I'm pulling and pushing. However, you see that this particular leak was possibly a little larger, and so it is milking it out. See, I'm getting it in the center. Can you see that? However, it is not staying there.
And is the echo doctor visualizing the
Yeah.
Yes.
back?
Yeah.
Yeah, you are seeing the fluoroscopy itself. You see that both ways it's being monitored.
How is the color flow now with the device there? Like?
It's not much.
Not much already.
Yeah.
See, the leak has actually substantially
Subsided
come
fully,
down.
yeah.
See, what was happening, Dr. Raj, the disc, when if I release the middle part of the disc in the center of the like the leak, it is getting milked towards the left atrium. So then I will have only one disc on the left ventricular side, which is the forcing side. So now what I have done is I have pulled the central belly also into the leak, into the left ventricle. Can you see that?
Yes.
Yeah, this is the original intention was to get the middle of the belly as show the previous picture. Show the previous picture. The previous. Yeah, this is how I wanted it to be placed. However, the moment I release the tension on the cable, the device sort of moves. Can you see that it's moving?
Yes.
Yeah, then I decided that we will rather put two devices, two blobs on the left ventricular side. The only thing now is that we should ensure that there is no impairment of the leaflet mobility. Can you zoom on the valve leaflet? Like make a zoom. Make a zoom now. Yeah, run it. So it seems to be fine. The quantum of leak is substantially less. You can see that. So right now, since my timer is running at 13 minutes, I am going to release it now and quickly close the apex. Come.
So can you also explain what the importance of the timer is? What are you looking for with the timer?
Basically, if I feel that if our procedure is getting prolonged by more than about 15 minutes or so, there is a possibility of thrombus formation on all the parts of the sheath and the wire, cable and all. So I would like the procedure, if it is going more than that, then I am going to be like using, get me a 6 vascular plug. I'm going to be not wasting too much of, I'm going to be giving heparin. Come, give 6 vascular plugs, flush sister. I'm going to close now the apex. Srija, are you happy with the? Can you put the color and show the color across the?
Very, very less, sir.
Okay, sister, I want a flush. So now we are going to close the LV apex with another vascular plug. the protocol that we follow is we take a syringe and we connect it to the sheath so that the come, give me the device. Where is give the plug. 6 mm, not that one. 6 mm Amplatzer vascular plug 2.
So what is the largest sheath size that you can close percutaneously?
We have done it for about up to 9 French. We have used a 8/6 PDA device in those patients. Of course, surgically we have gone larger when we have taken this is not the same previous Amplatzer vascular cable. Take a 6 plug.
Up to 12 has been used.
Percutaneously.
Dr. Wilkins has said up to 12 French sheaths has been closed percutaneously in this center.
And this was in which center? Is it Dr. Gerard or?
Yes.
Okay, Dr. Jerry, then how do you close with a 12 French? Do you use surgery or you put in a large device?
I haven't done up to 12, I've done to 9, and I put a device in the closure on them.
What device you use for a 9 puncture?
Just the same approach, ductus.
Occluder, okay.
Duct 1.
Okay, now I'll tell you one of my experience about using a vascular plug versus duct occluder. The advantage of a duct occluder is that it has got a fabric. Sister, hold it here. The advantage of a duct occluder is that it has got a fabric, and so we feel that the chances of closure is far better. But one of the problem is the wires are pretty stiff, and so what happens is it actually splints it splints the hole, and so some of these leaks, they tend to leak for a little longer time. So right now I am demonstrating the apical closure. Dr. Ronak is beginning to inject into the left ventricle. See that I am now progressively coming closer and closer towards the apex. Till the time I come closer to the apex, he keeps on puffing. So right now I am at the apex. So I am going through the, okay, enough, stop. So right now we have deployed the, can you see that whole sequence?
Yes.
Okay, now this is a replay. Put the screw. So you see that now we are approaching the left ventricular endocardial border. See, that is touching the LV endocardial border. At this point now we are taking it through the myocardium, and we are putting that plug there. So the time now is almost close to 15 minutes. So now I am releasing. So this has come out. So right now we will concentrate on the echocardiography. Srija, yeah, Dr. Srija is showing a live echocardiogram. That the plug is in the anteromedial position. The aorta is seen at the apical part, at the 12 o'clock position. Srija, show some live color. Yeah. So the device is okay. You see, hardly there is any big leak there. It looks nice. Can you see that, Dr. Raj?
Yes.
Yeah. So now I'm making a final check on the fluoroscopy. Make the fluoroscopy big. Fluoro big. Zoom the prosthetic valve disc movement. Show the prosthetic valve. Okay. Now can you center the table? Center the table. Make only fluoroscopy bigger. So the fluoroscopy looks fine to me. The leaflet mobility are complete and full. And Srija, last look at the transesophageal echo. 2D, 3D echo. Show echo big.
1 minute.
Dr. Raj, I would also like to tell that the other lab is also wired and ready. So we will be flipping shortly. Unless there are any specific questions on this particular case, I will move to the next lab.
We are waiting for you for the next one. How do you close the skin puncture site?
No, skin is puncture. So we don't do anything. We just put a gauze and we take it out. That's it. There is nothing like it is. It's just like femoral, focus here, focus here.
You put a sticky tape?
Yeah, sticky tape, exactly. Okay, see here, come closer. Yeah, actually there is nothing to show here, doctor. It's not bleeding, but the angle of the camera is not perfect for you to see. I need something like a reflector here to show you. Basically nothing is there, it looks fine. So there will be, the protocol will be, we will do a surveillance echocardiogram every 15 minutes. There will be one thoracic echocardiogram that will keep on be done in the next about 3 hours. And by today evening, like this is now here morning, almost 7 to 8 o'clock. So in the evening today, 7 o'clock, she will be commenced back on her anticoagulation, and we will build up her anticoagulation. And any opinion, Dr. Jerry? I think you are the master. So what is your views?
I think that was a beautiful example of, and the procedure time was so short compared to doing a transeptal approach, something away around a bend. That was impressively quick. Fantastic.
Yeah, I think as you pointed out, the fluoroscopic time is less. The radiation exposure is quite low. In transeptal, it takes a little longer. Fortunately, I selected one of the easier cases of paravalvular leak, which is a discrete single orifice. Unfortunately, there will be few patients who will have 3, 4 and all, and in those patients, definitely there will be a longer fluoroscopic time. See you in the other lab. Can you switch over to the lab 2 right now? The lab 2 is ready. Dr. Raghu, my colleague, is already ready there. Yeah.